So the objectives are to define with clients 3 newly available contraceptive options, maybe ones that you haven't used yet. Identify 3 new contraceptive options in development that intrigue you and are interesting to you. And think about 1 benefit and 1 challenge to the new option as you see it that will be most helpful in your practice. And these are our disclosures from the Ascent Center. So I think in any conversation when we're talking about the ability to control fertility, we need to lean in to reproductive justice. And the last thing I want to do is mansplain this concept. And I also don't want to miss any opportunity to share this beautiful human rights approach to thinking about reproduction. Reproductive justice, I imagine most people are familiar with, and it's founded on the basic idea that all people have the right to have a child, not have a child, parent their children in safe and healthy environments, and enjoy sex as they determine. And many images can represent RJ. I like this picture of a young Loretta Ross, who is now a MacArthur Genius Award winner, and a picture of her groundbreaking synthesis on the topic to give a nod to this insightful, justice-minded woman of color and her colleagues who created this movement and have so much to teach us about every aspect of our work. It's beautiful to consider that a human rights focus can be the default for all that we do. And it's been around for decades as a simple solution to the ridiculous pro-choice, pro-life divide that's destroyed civil discourse in our country. So we got to acknowledge when we're talking about new contraceptive methods or really any ability to control other people's fertility, that we got to center the RJ principles as step 1. So just a reminder and background. So why do we need new methods? There is a global human experience that people have sex mostly for fun, and fertility control is absolutely essential for gender equity and for planning healthy families. And current options don't meet all the current needs. Plenty of people are aware of the many options that they have and still not satisfied and still not happy, and haven't found an ideal method yet. So how do we get to the new methods? We got to conduct research to figure out what people will want, ideally, not just generate the things that we can. And then you got to go through this very rigorous FDA process, which is gaining a little bit of public awareness at the moment as mifepristone is under attack, a completely unfounded and obscene attack on its efficacy, because it's gone through not only all of these phases that I'm going to talk about, but millions of people have used it beyond, and it has a very well-established safety profile. So step 1, if you think like, oh, I've got, I'm working in this lab, I got this new chemical, I think it might prevent ovulation or kill sperm or prevent sperm and egg union, the first thing that you got to do is preclinical research. So you got to prove in animals that there's a range of drug that are not toxic to them, and then some safety, and then some efficacy in animals. And then you got to, if you're going to start human exploration, you got to submit an investigational new drug application to the FDA for human research, an IND. And then there's these 4 phases, basically 3 till you get approval. But the first phase is just, generally in a few dozen people. It's looking at safety and dose, and you have to just demonstrate that the dose that you're going to use is going to be tolerated. And then in phase 2, generally it's a few hundred people, somewhere in the 200 to 400 range generally, and you want to see efficacy and side effects. And the those studies take months to a couple of years. And about a third of products that undergo phase 2 testing actually make it to approval. And then for phase 3, it's a big study. So efficacy and adverse events are the focus, and it's generally over 1,000 people for contraceptive studies. And the study length is, it takes years, and about a quarter to a third of those actually make it through approval. And that, this is like a big expense. So companies that are supporting this want to have a very high likelihood of success. Okay, we can talk about some different things that are at different phases, these different phases. And then phase 4 is basically just demonstrating some element of safety and post-marketing use where the drug is already approved. And so actually, just to give some examples, most of the studies that we participate in are phase 2 and 3 studies. So there's a new IUD that we're working on. It's going to be called Myudela, or it was previously called Varicept. It's this kind of funky copper IUD that has about half the amount of copper on it. So we first did a phase 2 study with a couple hundred people, and then we have completed now a phase 3 study, and we'll see how that goes through the FDA approval process. And then we're also currently looking at a male contraceptive gel. Utah is one of the sites for that. And it has, and I'll talk about this a little bit more, but it has nesterone, progestin, and testosterone. And the current study that's ongoing has a couple of hundred couples, and looks like it has a favorable efficacy and safety profile. And we'll hopefully go on to a phase 3 study. So real world experience. The common factor here, though, is research is a pain in the ass, and it takes a very, very long time to get a new idea and a new product through. And I was thinking about this recently. Like in the like 2002 to 2007, I started really looking into like what was the contraceptive options that were out there that could be used. And I gave a grand rounds when I was a resident and on this, and wrote a review paper in 2007. And these were some of the things. This thing in the upper left was, I think this person was like marketing it before it was approved by anybody. It was called the spray-on condom. And I thought that was such a fabulous idea. Great marketing. I haven't seen or heard much of it since. This was the Silk's diaphragm, became the Kaya diaphragm. So that actually successfully continued. And then these are this middle IUD called Gynafix. It was basically a new copper IUD where this, and it is available in Europe. I don't think will be available in the US, but basically this knot at the top is put into the myometrium, essentially put into the muscle of the uterus. And then this very thin string of copper, which has basically the same amount as a Paragard, can be efficacious without really taking up any space inside the endometrial cavity. And then this is a vaginal condom, which has gone through several iterations. And then this is just another version of the of that Gynafix technology using a levonorgestrel sleeve. And again, available in Europe, not going to be available in the US almost certainly. So this is I think an interesting table of some of the things that got mentioned in this 2007 review article. And some of them have come to fruition. The Nesterone ethinyl estradiol ring is available. It's obscenely expensive, and hopefully the price will be coming down. CDB 2914 is ulipristal acetate. So we do have an emergency contraceptive pill that's available. The ring and the IUD have been investigated and probably are not moving ahead. Subcutaneous Depo-Provera has been available now and is FDA approved. And here are some other things that have successfully navigated the FDA process. And then here are some things that are under investigation now, and we'll talk about a few of those. And it turns out if you're super into this stuff, this is a really interesting resource. That's available online. And what they try to do is keep up with all of the items in development and track them over time and add new ones as they come along. So 243 items in the Calliope database. Check it out. There's all kinds of super interesting stuff there. So now we're going to kind of jump into some of the options that are available. And, the most commonly used method aside from permanent contraception is our oral methods. And the vast majority of oral methods in the US, except for the progestin-only pill, contain and have for a very long time ethinyl estradiol, which definitely produces a bunch of side effects that people don't like and increases the risk, the most significant and concerning risk with use of these products, venous thromboembolism, DVT, PE, stroke, heart attack. These are rare events, but if we could reduce them, that would be something. So hence the investigation and the drive to try to find new estrogens that could have favorable cycle control and avoid the side effects and the risks associated with the use of ethinyl estradiol. So estradiol by itself, the natural circulating estrogen, is one of those things, and that's being used in a few new places. Estetrol is a unique component of estrogen that's really only found in the fetal liver, and estradiol valerate basically converts to estradiol. So some progestogens that are in development, drospirenone has been around for a very long time, as Yaz and Dynagest. These are novel progestins that do not impact the carbohydrate and lipid metabolism. They're very focused just on a specific progesterone receptor. And there's combinations of these things that are, some of which are now available. And there's also increased access. We may see the day where there's actual over-the-counter access of birth control pills. We're getting there. And then first will be progestin-only pill for sure. So as I mentioned, the main reason that people discontinue combined oral contraceptives is side effects. And the main risk is venous thromboembolism. And those are all driven by the ethinyl estradiol in pills. So there's a big drive to try to come up with some better things. And Zoli is a one of these things that's available now in Europe. It's combined oral contraceptive with estradiol and it's called NOMAC or nomegestrol acetate. And then the estradiol valerate and Dynagest product also now available. So SLIND people may have heard of, and this is a really interesting product. You know, we've had Yaz around, it's a combination of drospirenol and drospirenone and ethinyl estradiol and Yasmin, and you know, around for a while now. And so this is a drospirenone only pill, removing the estrogen component. For a progestin only pill, this has a longer half-life than norethindrone, so that issue with timing of the pill every day becomes less of an issue. And you can have up to a 24-hour missed pill window. And it has a favorable bleeding profile for a progestin-only drug. And the Pearl Index, the measure of pregnancies if 100 people use this method over the year, is 4, a little bit higher than most study drugs. And there's a rare side effect of hypokalemia because you're interfering with potassium transport in the renal tubule. So the other thing that I haven't mentioned is this stuff is expensive. And Jessica Lewis-Capral, a nurse practitioner who works with our group, is the master at navigating these access to issues to try to make things affordable for people. And it turns out SLIND has a manufacturer coupon on its website, and you need to write down the prescription as brand only, dispense as written, and run it with the manufacturer coupon. And that brings the cost down to under $9 a month. So a worthwhile consideration for that. And I would certainly want to encourage people to use JLC, Jessica Lewis-Capral, as a resource for navigating these kinds of things. And then just looking a little bit deeper into the drospirenone, there's another combination that's coming. So drospirenone estetrol, and will be in a kind of combo 24-4-day regimen called NJECTABLES. And there was a combination of 2 phase 3 studies with 3,000 participants, and included a significant number of people with higher BMI, over 30. And the Pearl Index overall for this combination was 1.5. So a lower pregnancy risk than the drospirenone only, though not compared head to head, clearly. And then there was appeared to be a slight rise in the Pearl Index as BMI rose, but much better than a lot of things. So again, some examples of some new things with new and a relatively new progestogen with some new delivery methods, but having wide access to a progestin-only pill, SLIND, that has a longer half-life, that has greater range of use and is more tolerant of some irregular scheduling is really I think a significant advance, especially if it has a better bleeding profile. All right, now we're going to switch gears and talk about some vaginal rings. There's some old stuff that we just actually don't really see. Of course, there's NuvaRing. People know about that. But there's a progesterone only ring that's been available in South America and low and middle income countries for a while. I'll talk a little bit about that. And then there's some nesterone rings, which are available and working through the approval process now. And then there's some really, I think, future wacky stuff that's cool to think about and has the ability to deliver multiple drugs simultaneously. And I'll show you some pictures of that stuff. So the old vaginal rings are basically user-controlled methods. And the idea behind this progesterone-only vaginal ring was for, to extend the contraceptive efficacy of lactational amenorrhea. So lactational amenorrhea is, when people are postpartum, and then in the first 6 months of use, if you are exclusively breastfeeding and in the first 6 months after birth and haven't had return of menses, there's 98% efficacy in that time for lactation as a method of birth control, which is really phenomenal. Like, you got to do nothing aside from what you're doing, which is great. And then the idea behind this progesterone only ring is that you could extend that as children took on other types of food and you were beyond the 6 months, maybe when if your period had come back, you could insert this ring, and the ring lasts for a year. And you could control basically putting it in and taking it out. And it's been used and never went through the FDA approval process or marketed in the US, unfortunately, and I don't think it's going to be. So, however, there is a new ring that has been FDA approved, and is called Annovera, and it's nesterone and ethinyl estradiol, and it's also one ring lasts a year. You can use it for 13 cycles, and nesterone is an interesting progestogen. As I mentioned a little bit earlier, it's one of those novel progestogens that is super focused on the progesterone receptor and doesn't really have any interaction with carbohydrate or lipid metabolism, so fewer side effects. And it's unfortunately not available orally. So all of the methods that we're going to talk about that use nesterone are gels, rings, patches, things that can be absorbed through some mucous membrane or skin surface. And so anyway, Annovera is available. And you think about, right, like you could go to the pharmacy, pick up a single ring that would be good for a year. That's super cool. This is also, and I don't understand the pricing of these things, but if you go to the pharmacy, and I need to do this currently, but up till pretty recently, it was like over $2,000 for the ring, and so your pharmacy coverage is pretty unlikely to cover that. However, there's also a savings coupon at savings.annovera.com /activate, where you can get it actually for nothing. And then we're participating in some studies with the Contraceptive Clinical Trials Network through the NIH that are looking at a nesterone estradiol combination. So this is the natural occurring form of estrogen, or the most common naturally occurring form of estrogen in humans, and seems to also have a favorable efficacy and safety profile, and more to come on that. Okay, so here's the super cool stuff. So there are rings in development that use what's called a scaffold, where you can actually insert different pods into this scaffold to deliver potentially multiple drugs. That could be super useful for For multi-prevention technologies, like, for example, delivering a progestogen that could serve as contraceptive and, an anti-infective, antiviral agent that could prevent transmission of HIV or HSV or other viruses. And then Ovaprene is also not exactly, it's a ring and has kind of a mesh inside it that releases ferrous gluconate or ascorbic acid that it impedes sperm motility. And there's a trial that's just about to start in the US looking at that. So more to come, but that, non-hormonal method that it could be user controlled, that could be also a very significant advance. And then Twirly is the current levonorgestrel ethinyl estradiol patch. Obviously a patch that stays in place has more stable levels than the pill. You don't have to remember taking a pill every day. You don't have first pass metabolism, meaning like a pill gets into your stomach, the blood level that's achieved has to go through your liver first. That doesn't occur when when the drug is not delivered through the GI tract. And then it's used as a weekly application, 3 weeks in a row, and then 1 week off. And certainly you can use it continuously. So here's some efficacy data for Twirly, again, based on BMI, and there's a rise in pregnancy rates for larger people. And then unscheduled bleeding and spotting are quite frequent, occurring more than half the time in the first cycle and just under. So continuation is definitely an issue there. And then in these, in the main trial, there is there were 5 patients with venous thromboembolism, all with a BMI greater than 30. And a rate of 25 per 1,000 for this is definitely an eyebrow raiser. The other version of this is Xulane, which is available. All right, and then Phexxi is also FDA approved. Unfortunately, it's prescription only, which means it's a barrier to access. But that's the pathway that the company chose to pursue with the FDA. And once you head down that pathway, that's where you got to live. And that was sort of I think a business calculation, which is unfortunate for your user access. But it's a user-controlled, non-hormonal, on-demand method. It also works as a lubricant, and there's a current ongoing trial looking at it as a microbicide. The pregnancy rates are definitely on the higher side in the, especially for a trial also, but 14% in the first year is, closer to like real world condom use, and is, definitely I think an issue of concern. But there are some people who are using it, and people who are happy and satisfied with it. So this is a really interesting drug, I think, that's still in relatively early development, PPCM, polyphenylene carboxymethylene. And there's this company in Boston, Yazo Therapeutics. They've been working on this for a couple of decades. And the idea of this molecule, which comes in a gel, is that it can isolate sperm and basically make the acrosome, destroy the acrosome and prevent the acrosome reaction, so fertilization from happening. and it can also simultaneously cover viral and envelop viruses so that they can't, they can't replicate and cause sexually transmitted infections. And there's also potential for this to prevent airborne infections with nasal application. So there's some in vitro and animal data demonstrating efficacy, and I believe they're queuing up for some human studies. And then multi-prevention technologies, really the things that are currently available are condoms, which can prevent both pregnancy and sexually transmitted infections. Lots of humans have used those and long history of use. There's a great need for this. Clearly, there's been huge time, effort, and expense pushed toward multi-prevention technologies. There's, almost 2 million new HIV infections per year. U.S. Sexually transmitted infection rates are on the rise. I just saw this morning, actually, chlamydia rates are up another 7% in 2021. And gonorrhea rates are also on the rise. So, having methods that both prevent pregnancy and sexually transmitted infections would be incredible. And the very long-term efforts with this have not yielded a perfect product as of yet. There is a dapivirine ring that has levonorgestrel that's already been tested, and I am not sure what the regulatory bump with that is, but not in use yet. And then I wanted to talk a little bit about over-the-counter OCPs. Clearly, there's a whole bunch of opportunities to get oral combination, progestin only or oral contraceptives online without actually seeing anyone. And some of these are, have some reasonable pricing structures, which is great. And then HRA Pharma submitted the first application for an over-the-counter progestin only OCP, the O pill, which will be 75 mics of norgestrel. And lots of information on OTC access of the pill on freethepill.org. Looking forward to seeing more information about that. And then I just wanted to put in a quick little plug for dispensing emergency contraception, Ella, with new prescriptions of whatever you're dispensing. So it turns out that the majority of people who begin any prescription of the birth control pill by the end of the year are not using it, and may get into a place where they have a contraceptive method gap. And having a prescription of Ella on hand is great, a great backup, and people can, give it to their neighbor, friend, sister, aunt, whoever. Anyway, so I definitely make it my practice and strongly encourage people to also add a prescription for Ella when prescribing a new method of birth control. And just acknowledging, it gives you the opportunity to talk to people to say, hey, listen, this may not work out. And if it doesn't, come on back. We'll help you get the next thing that works for you. And if you're interested, we're happy to give you a prescription for emergency contraception. The most effective morning after pill is this thing called Ella, which you need a prescription for. I'm happy to send it to the pharmacy with you when you go pick up your pills. So as far as implants and injectables, this is really another opportunity. In many countries, injectables are preferred as and implants. They're set it and forget it, discrete methods that you don't have to, unlike an IUD, you don't have to take your pants off to get one. And there's some really interesting delivery mechanisms coming on this. There's one of them are microneedle patches that provide an alternative delivery for hormonal contraception. So they're essentially like a postage size stamp that has very fine penetrating needles in it that can deliver a drug from a gel patch behind it. Biodegradable implants, long-acting in injectables, there's a whole group of people who are devoted scientific rigor and commitment to essentially coming up with new ways to get long-acting drugs under the skin and to people in acceptable ways. So more to come on that. And delivery technologies could potentially involve microchips where you could turn on and off an element, maybe a progestogen or delivery of an NSAID, with a remote switch that has a microchip for your IUD or implant, depending on, and giving user control. The goal of the microchip is to have an insertable device with controlled drug release. And then the Bill and Melinda Gates Foundation has recently invested quite a bit in this. Fabrics that have electrospun drug-eluting fibers, fast dissolving vaginal inserts, bioadhesive vaginal films that could last, so two ways to address something lasting shorter or longer. And then some novel IUDs that are in development. There's been an indomethacin IUD available in China for some time, which addresses, which can decrease bleeding. There was an attempt, Vivian Brache in the Dominican Republic worked on anulopristal IUD. This is the same stuff as Ella, and unfortunately did not prove to have as favorable bleeding control as hoped. And then there's some new smaller IUDs. The Mona Lisa is something that's already available in Europe, and basically it looks like a small Paragard, and so the plastic portion is smaller, and then the copper wire around the stem is has a slightly larger diameter, so it delivers the same amount of copper. And a recent Contraceptive Clinical Trials Network study looked at that and showed that to be efficacious, and we may see that as an option for nulliparous people, and it might be a favorable option there. And then the myudela, which I had mentioned, is this funky copper IUD that comes in a very narrow sleeve. So if you think about Paragard is really the widest IUD for insertion when you fold the arms in. This thing is, like the Skyla, similar diameter, so very thin diameter, and it comes preloaded, pre-cut strings, and has half the copper. So more info on that coming, and then that same approach could be used to deliver a levonorgestrel IUD. And then, just as far as expanding access to methods that are already available, data from our group and others have shown that we can use levonorgestrel IUD in ways that are, I think, more helpful for people. You know, the levonorgestrel 52 milligram IUD now, so Liletta and Mirena are both FDA approved for 8 years of use. We have some early data from an RCT from from Planned Parenthood Association of Utah showing that the levonorgestrel IUD is non-inferior to the copper IUD. So Liletta and Mirena can be used for emergency contraception. There's definitely people looking at the potential of self-removal as a increase, as a way to overcome an access barrier for removal. And we've been trying for a while to accrue some data to demonstrate basically you can put an IUD in at any time, regardless of where somebody is in the menstrual cycle, as long as they have a negative urine pregnancy test. And one of the studies looking at that with the levonorgestrel IUD, we basically aggregated people from a whole bunch of different studies who reported unprotected intercourse 6 to 14 days before they got their IUD placed. So if, the concern is a luteal phase pregnancy, like, oh, these people had sex a while ago, their pregnancy test isn't yet positive, but they're going to be pregnant later, this is that study. So we looked at 187 people who had that exposure. There was one pregnancy, so a 0.5% pregnancy rate. And then also we've looked at this with the copper IUD. In that case, we only had 134 people, but no pregnancies. And then there's 2 other papers that have reported similar outcomes with no pregnancies. So the 3 papers together, that's 250 people who've had copper IUD and with people who've had unprotected intercourse 6 to 14 days before they had their IUD placed, no pregnancies. So, this is now actually this approach, being able to place an IUD at any time with a negative urine pregnancy test is something that's now endorsed by the Planned Parenthood National Medical Committee. So we're not totally out there. Okay. Alex, what's our time story here?
So right now we are at 8:19, and I think the goal was to be done at 8:25, so you could have about 5 minutes for questions.
Okay, thanks. So everybody wants to talk about, well, maybe not everybody, but lots of people are interested in male methods, and certainly male non-hormonal methods would be awesome. It would be absolutely fabulous to figure out some way to hijack sperm development or sperm motility or the ability of sperm to penetrate the egg. But probably the most favorable stuff that's going to be available the quickest are going to be male hormonal methods. So I'd mentioned we're currently doing a phase 2 study of this Nesterone testosterone gel. And enrollment is now complete. Actually, this slide is a little bit old. And we're continuing to follow people. And those data for this phase 2 study will be delivered to the FDA, and hopefully we'll proceed to a phase 3 study. And so Nesterone, this is the same stuff, same progestogen that is used in those rings like Annovera I was talking about, and the new one with Nesterone and the estradiol ring. So it works the same. It's the same process of inhibiting GnRH and LH. It's just the downstream effects in this case, instead of preventing ovulation and follicular development, it's doing 2 things. It's preventing sperm development and sperm maturation, and it's preventing testosterone production. Thus, the second drug in this gel, which is basically testosterone as an add back. And and people in the study have been closely monitored to see, and very few have needed additional testosterone. And we will have more and better data to share on that. This is Nesterone, as I mentioned, is not available orally. So a male pill is tough. However, there are some newer androgens that might work, and the long name dimethandrolone and decanoate, DMAU, is potentially one of those things, and its counterpart, 11 beta MN TDC, is another. But both have been shown to be safe when administered orally. So there is some potential. And then, sorry, I skipped over MENT, which is being developed in an implant and an androgen with high tissue specificity, and decent but not perfect sperm suppression. So the current challenge with this is developing a new implant polymer where they can deliver a greater dose. More to come on that for sure. And then, coming up with a new way to do vasectomy that didn't require incision, just had an injection into the vas, maybe that was reversible. This has been used many times in China, and there is a chemical vasal occlusion method available there. The efficacy can take a while, like 1.5 to 2 years, and reversibility has really only been evaluated in a very, very small group. So there is potential, but I don't think we're going to see this anytime soon. And while in China, over 600,000 men have received this. In the US, basically 20 rabbits have. So we're quite far behind. The upside of the FDA approval process is, in the end, you are very, very likely to get a safe and effective method. The downside is the process is so rigorous and so expensive that we miss out, I think, on a lot of potential advances. So there are tons of possibilities out there, and some will actually be realized and can actually really help people. So we'll continue to keep an eye on things as they develop and try to figure out which those are, and think about what we know about what people want and can best use, and is going to meet people's needs, and work on developing methods that are going to have that kind of delivery. So that's a wrap. Happy to answer any questions if I can. I don't think anyone at this point maybe doesn't want to see pictures of snow anymore, but some do.
Thanks, Dave. Everyone feel free to ask questions. Erica, maybe you could open the exit poll while people are asking questions.
I will hop in. Dr. Kai, it's Kai. How are you? I have several, but I'm going to just do a few. Thank you for sharing this talk. One thing is about the copper in the new IUD. What do we think the advantages of having less copper? Like, what will be the side effect for patients?
Yeah, so great question. Thanks. So with myodela, it's interesting, right? Like, so it's got half the copper, but it's placed just inside the cervix and then at the cornua. So ideally, it's at the two most important places to stop sperm transport. Like, you get most of them, there's a good reason that sex is messy. Most of the sperm actually never get into or through the cervix. They end up in the vagina or outside. So you got to stop as many that get through. And then having copper in those two places, I think, is an effective approach to doing that. and having half the copper should reduce bleeding and cramping. And there's some head-to-head data. So there was like a 2-to-1 RCT done in the Dominican Republic, looking at this IUD compared to a T380. It's not exactly a Paragard, but very, very close to it. And basically and participants were masked to their treatment assignment. And the people who got the new IUD were more likely to continue it, less likely to discontinue for pain or bleeding, and less likely to report pain or bleeding as an.
Got it.
So I think, this is promising. And you think about Paragard. Paragard was FDA approved in 1984. That's when the Macintosh computer came out. Like, that's the thing where it was, like the screen and the disk drive in one. So a lot of technology has happened in the interim, and not so much about technology for copper IUDs. And there's like an increased demand for it now. People want hormonal methods.
Am I allowed to ask more? No, Jacqueline, go ahead.
Yeah, David. Thank you. Can you hear me?
Yeah.
Oh, okay, I wasn't sure. Yeah, so I'm sorry about the text on, I appreciate your help on this, but that Corlin effect, I mean, the patient was going to go on it for her cortisol or whatever, and they told her that she can't use birth control pills, both the pharmacist and her endocrinologist.
And they the recommendation, like, find some other contraceptive method.
Right. And right now she went off the pills and just using condoms. And probably spermicide.
Yeah, that so the dose, so this is let me just give some background here for people. So Korlym is mifepristone, and Jackie has a patient who is using it for Cushing's, who's so basically it's not only a progesterone receptor blocker, but also has cortisol effect. And it's available in a different dose, but anyway, Jackie had a patient who was prescribed this for her endocrinologic condition, and I think had been using birth control pills. And the recommendation, per the package insert on this, is to not use both simultaneously. And the theoretical idea here is that the birth control pills, the exogenous progesterone there could potentially reduce the effect, or vice versa with mifepristone at the progesterone receptor level. And my understanding is there are no data to confirm that. That's the package insert says that because when they did the study, they to get approval, they didn't want to recruit anyone who was using a progestogen because of the potential for interaction. So I think it comes down to what the package says and what the real world use is going to be. And I think the providers are going by the book, and there are other options hopefully for this patient, and I'm happy to try to talk to those folks. Alex, you feel like you got something you want to add to this?
No, I think you covered it well.
Anyway, it's one of those situations, I think, where FDA approval bumps into personal reality. And it doesn't all work perfectly, for sure.
Okay. And then just one other question.